Yeah, no worries.
So, good evening, everyone. My name's Ollie Coburn. I'm the registrar at BASRaT, and we are really pleased to once again be partnering up with Physique for tonight's webinar. Charlie's done loads of hard work in getting this together, so big thank you to him and his team. We're just here to host. I'm here to do the techie bits. So I'll throw it to Charlie. He'll do the intros, and then we'll get cracking.
Yeah, brilliant. I'm just trying to figure out how this all works. I've just lost the screen here, but we'll start. There we go. Yeah, no, thanks. Thanks, Ollie. And thanks, Andrew, for taking the time this evening. Really appreciate it. I'm sure a lot of us will learn a great deal this evening. Obviously, thanks, BASRaT, for helping put this on with us. But more importantly, thanks for everybody who's logged on and joined us this evening. I think we had about 1,000 odd people sign up in about 2 or 3 days. So no pressure, Andrew, but it was a popular one and stuff we want to do more of. So more speakers, more topics. So please let us know things that you want to hear more of. Any specific speakers or topics or discussions. Love to hear your feedback. So we can keep doing this on a more regular basis, really. But I think everyone's here to listen to Andrew, so I think we'll go straight into this. So Andrew, do you want to introduce it and take it away?
Yeah, I'll just do my screen share and then we'll get going.
Yeah.
Typical. Go right back up to the top.
Oh.
All right, lovely. So yeah, I'll do a quick intro, say hello. Obviously 9 years in football at the moment, currently at Bristol City, 2 years at City. Things have been going all right. Obviously you probably all saw the news recently, but we're doing well. Great club to work for, really forward thinking regarding the injury front, prevention, management. We run our own in service quite a lot, and tendinopathies are something that we look strongly at. We try and control, we try and manage. You know, we've had people like Peter Maliares come to the club and do presentations for us. I speak to him quite a bit as well. So I thought I'd just give you an idea through this presentation of how we look at managing a patella tendinopathy specifically. Tendinopathies are things that, as a group of therapists, physios, sport therapists, masseurs, S&C, sports scientists, we deal with tendinopathies a lot. Achilles, patella, in the groin area, shoulder. So a huge range of issues that, quite frankly, can be very awkward to deal with. So I'm just going to run through this presentation around patella tendinopathy specifically, give you an idea around the way that we manage the specific case. So this is a real life case that I'm going to share with you. And then obviously you guys can ask me any questions, and feel free to ask me anything you want regarding the clinical management. I'm by no means right on anything that I say. I'm more than willing and happy to speak and discuss about anything that you guys want. I'm very open to all of that. On the front page there, you can see my Twitter and Instagram if you want to have a little look. I'm not the biggest poster, but occasionally post some stuff about sort of rehab and things that we're doing at the club, which can be quite interesting, but I'll leave that to your own mindset. So patella tendinopathy, little introduction. So like I've already mentioned, can be a little bit of a pain for us therapists in the sporting world. I think there's a bit of data has come out recently saying that around 18% of all tendinopathies are patellas, which doesn't sound like a lot, but when you consider the amount of tendinopathies that are in and about, that is a large percentage that we have to deal with. And they can be very, very problematic in their long-term management, short-term management, and for a player's whole career if we're not careful. By definition, a chronic condition, as you're probably all aware, and it can affect athletes of all ages. It's not just the professionals, it can affect athletes in their developmental phases and towards the end of their career. We all know the signs and mechanisms of high impact, high load, and the tendon itself can actually become disrupted in the central portion and or the paratendon. Quite often it's the central tendon that we see rather than the paratendon and the patella. Whereas in the Achilles, obviously the paratendon is quite a large involvement. Like we've already mentioned, that repeated stress and load constantly going on in football. So the high number of sprints, accels, decels that we see on the GPS data correlates very, very closely to how a tendon will suddenly start to become inflamed and aggravated. Both insertional mid-tendon irritation can occur within the structure, and these present quite similar. There's a lot of research around that, which shows that the treatment is very, very similar throughout its whole pattern and the way that we manage and control the patella tendinopathy. You'll hear me talk about references throughout. I have got a very extensive list at the end, so I will leave that there for you to look at and feel free to use it. Elite sport, as I've mentioned, the chronic form of patella tendinopathy that we see is often developed when there are massive spikes within load, or when there's been a change in load, not necessarily a spike, just a change. That could be a surface change. It could be too much rest. Rest is one of the key things that we never want to do. So we always have to be aware within our sport and with our athletes what is going on with their load. And this is something that is very, very important when we look at the when. So when has it occurred? Has it occurred when we've had a high 1 week load? Is it occurred when we've had a high 3 week load? So a more chronic area. Is it that we've had 3 games in a week? Is it the player's history? There's multiple things for us to look at. And the variability of football, especially, that we've seen with our players, it's very hard to predict when a patella tendinopathy will occur. We talked about the wear, so mid-tendon, insertional parts of the tendon. And these long-term strategies we're going to talk about after we've spoken about the case study. And hopefully you can get a picture of how we deal with them and how we manage them. So the case study that we're talking about, so like I said at the start, this is a real-life athlete, 26 years of age, so arguably in the sort of peak age for a footballer. He's an attacking player, so on his GPS data we notice high amounts of sprints, high amounts of total distance and high speed running. So normally this player will achieve in the region of 18 to 22% high speed running for total distance, which is from a championship level. That's in the top 5% of championship footballers. So a high amount of accels, decels, change of direction, and a very, very powerful athlete. You see that I've put the history, and it's vital. The management of this player was vital, that we knew his history, and we knew when he arrived at the club that there was an ongoing history of patella tendinopathy, managed in the past with eccentric loading, so predominantly looking at, I don't want to say the old school method, but a very basic Alfredson style protocol of eccentric loading. And that actually seemed to be very successful, and the player was often very happy after the pre-season load and the little mini spike that the tendon would settle, and he'd maintain a 1 or 2 out of 10 at worst throughout the season. And in his history, this was an isolated incident. There was no other injuries to go with it, and nothing that was of any note. So it does show you that we knew what would work for the player, but we had to find a way of trying to stop this constantly coming back and affecting his return to play, especially during the pre-season stage. So the usual low-grade symptoms that the player had, he would be, like I say, more than comfortable loading that tendon and maintaining his training. But we had a change of load in this one instance with the player. So he returned to training a little bit later from a summer break due to other commitments in international football. So his load spike was a lot higher. So that's obviously, we already know now that is probably the cause of why his patella tendinopathy flared. So spike in load, so like we've all discussed, is considered an acute 1 week or a previous 4 week average. You'll all have read all of the research and data by Gabbert, and lots of arguments for and against it. But it's quite likely that this was where the injury occurred and why it happened, because it was a massive spike for the player. So during the 3rd week of the training schedule, when he was back, he had 2 45 minutes games on a Tuesday and a Thursday, which for all of our other players is absolutely fine in week 3. But for the player in question, this caused a spike of 8 out of 10. So a 24-hour pattern, he reported an 8 out of 10 on VAS scale. So a very crude measurement, but an easy one for us to follow on a subjective marker. So the Friday session, after the Thursday game, he was removed from because the pain was just too much. There was talk about whether there was a hyperextension mechanism in a single leg jump during the game, but on video review, this was not clear and probably had very little to do with the patella tendinopathy flare-up. So this discomfort was reduced. We did some gentle eccentric loads with him just to get him back into the habit. As being a footballer, his adherence to his rehab was not fantastic, even with constant monitoring. It's impossible to stay on a player's case 24 hours a day. But the player was able to pinpoint pain. So this was noted on the infra-apex of the patella and the proximal patella tendon. He had reduced knee flexion, and passive extension was also reduced due to pain. At the time, we were diagnosing insertional tendinopathy with a potential fat pad irritation if there had been a hyperextension that we couldn't find on video review. So we performed an MRI 24 hours after this assessment. So the distal patella tendon was normal, but there was thickening within the central tendon and into the proximal attachment of the patella, which measured 7.4 millimeters in length. So a fairly substantial amount of irritation within the central portion. He has got a prominent inferior patellar pole, but there was no calcification found. So we knew that the line of force through the patella hadn't changed. So we were able to rule that one out. The MRI did, however, suggest that there might be a partial interstitial tear of the central tendon. So this then made us think about a secondary diagnosis. Were we dealing with specific patella tendinopathy, or had there been a secondary trauma through this jump or hyperextension which had caused the tear? We then took the player straight for a dynamic ultrasound scan, which confirmed no tear. So that was a relief to us. There was no tear on a dynamic ultrasound, but obviously the tendinopathy was confirmed. So treatment plan, we went from here. So we knew we had to see a consultant. So we were going to go and we went and saw Mahrez in London to ensure that we covered all bases and to make sure that he was happy that because of the length of time the player has had this over the years, we were managing it in the correct manner, and did we need to do anything else in the potential off-season or international break? So be that injection therapy or any other sort of extra therapy that we could potentially use to help speed up any recovery or healing. So we discussed a comprehensive management plan. So we were prescribed then to look through energy storage and energy release drills, so eccentric loading and heavy loading, so through eccentric and isometric, and then to look at energy release drills, which is your plyometrics. Our pain was our key marker within all of this. So the consultant had advised us that the VAS score should never change from a 3 out of 10 through a 24-hour pattern. And that was going to be a big marker for us throughout the whole of this rehab, was a 24-hour marker of 3 out of 10. So after we discussed that and we knew that that was our stable diagnosis, we agreed then that we would try GTN patches, right, which we will talk about later on through this presentation. We were to review the player's nutritional supplementation, and we were then to look at possible alternative treatments if this didn't work. So the consultant was very, very clear that our initial plan would be to load, GTN nutrition, and then if there was no success, we could look down alternative treatment. So we could do PRP, we could look at hyaluronan injections or cortisone. But the consultant was very, very clear that there is lack of evidence regarding these two injections. But given the nature of the sport that we live in, we were quite happy to possibly look at these, and the consultant was more than happy that there was no risk to the player if this was completed. And then obviously after that, we were then to review, and there was discussion in off-season of a patella tendon scrape, which we obviously have not got to, luckily, but that was spoken about, and we looked at the options of when we could and couldn't do it. I haven't spoken about it in this presentation because it's quite a detailed operation, and obviously we didn't use it. So that's something maybe for people to look up at another time, is patella scrape. But we did talk about it, and we decided against that if we were successful in our treatment. So the contributing factors with this player. So mechanically, very, very hyperlordotic. So has quite a dramatic lower cross syndrome, if you want for an easier way of looking at it. Has had numerous hamstring issues due to the way his patella sits and the way he moves. But the hamstring issues we've got on top of, so we thought we were quite happy that this wasn't a contributing factor to the players' issues. Loads in the gym perfectly well. Loads very, very heavy. He's one of the strongest athletes in the squad. And as we could see from the way he plays, in the position he plays, lots of high speed running, lots of sprints. So we felt that we had his mechanics well. The player's top speed is 10.3 meters a second. So I'll leave you guys to work that out, but that is very, very quick. But the posture was a potential problem we might want to consider at another time. We looked at foot posture as well. I'll talk about that a little bit later on as well. That could have been a potential issue or cause leading to the injury. So treatment. What did we look at? What did we do with the player? First of all, with regarding the treatment, obviously it says loading first of all, but we wanted to make sure that we looked at every single little bit of detail with the player. We wanted to look at, like I say, his feet. We wanted to look at his power. We wanted to look at energy balance from side to side. And when we did a lot of our testing, we found that there was relatively good balance from left to right. So there was no reason for us to think that the player was right side dominant or left side dominant. We knew through counter movement jumps, we knew through single leg jumps, and we knew through a triple hop over distance, which is a crossover hop mechanism, that there was only 2.3% difference at a max. So we were quite happy that the player was very even, and we looked at his GPS, which also backed up these theories that I think on his worst day he had a 2% right to left difference. So we knew that his running mechanism was good, and that wasn't going to be a cause or a problem for us to worry about changing his loading. So we then went straight into the loading. And like I said, we went straight in with isometrics. So we went very, very heavy on the isometrics as soon as we possibly could. So the player was performing single leg, knee extension isometrics. We completed these as often as we could. Again, bear in mind, we were always constantly reviewing that subjective score. So using our club dashboard every morning, using verbal communication, and then a text every evening to ensure that that remained stable. So player began to load 30 seconds times 5. We progressed up through very, very heavy weights very, very quickly. Just get some of the exact weights. So we started off with a 24 kilogram single leg hold. 30 seconds times 5, as I said. The knee was at 45 degrees, so at a point of minimal pain. So we used a 1-to-2 work ratio, and we did work bilaterally. Always work bilaterally in a system like this, or we do it at Bristol City to ensure that we then don't create an imbalance. Like I just touched on, the reason I touched on it is that the player in hand was balanced. So we did not want to create any tilt or any uneven loading throughout the body. So after we made sure this was stable, loading was increased as quickly as pain was allowed. And by day 3, pain on the 24-hour pattern remained at 3 out of 10. So we changed to a 4:45 seconds. So this is advocated by many, many research articles as your isometric loading pattern. And again, it was on a 1-to-2 ratio. And we were up to 32 kilos by day 3. 32 kilos might not sound like a lot, but on a single leg hold for 45 seconds, that is a significant load. I advise you to go away after this and try it and see how it feels. I can probably only complete 2 sets before I'm done. I'm shaking and I can't hold it. So it shows you that the player was able to tolerate high load even with this issue, and we were able to keep the pain score stable. We introduced the GTM patches at this stage at day 3. We felt we had some stability, even at 72 hours, that we could apply an alternative therapy. Obviously with the GTM patch, as hopefully you guys are all aware, their side effects can be quite significant headaches. So when we applied the GTM patch, we needed to ensure that only a 2 out of 10 headache was achieved, and the GTM patch would be adjusted to suit. So we started off with probably just less than a quarter of a patch. And the player was very happy with this, and we progressed that up to half a patch within 2 days. with no headaches. So we were very lucky on that front that there was no headaches and no skin rashes were developed with the GTN. The pain in the patella remained stable until day 6. So we remained on that weight and we remained with the GTN. We gave ourselves another 72-hour window to see if there would be any change or adjustment. Would the player react very well to the GTN? Would the player react well to the GTN and the loading? We knew that loading and isolation had worked. What about the two together? And there'd be no reaction, so there'd be no change. So we were quite happy to continue with the GTN patch. And then we began to look at slow and heavy metronome loading. So a 5 up, 5 down count. So very, very slow and very, very heavy lifting. So 5 sets of 5. The weight was reduced initially to 20 kilograms. And we completed these every other day. So isometrics were increased to 36 kilograms 3 times a day, every day. So as you can see, the amount of loading you're starting to put through this tendon is dramatic. But no fatigue is really being applied. There was minimal fatigue post the first heavy slow day, but after that, the player was fine. Increased volume intensity, the pain still remained stable. So we're really happy that we could move to endurance loading through range. So we began to use the inverted leg press. Excellent piece of kit. Ours is a bilateral leg press. We would have loved the single leg unilateral press. Unfortunately, we don't have one at the club just yet. So we were on 3 times 15 of heavy and through range inverted press. We began at body weight, so 84 kilograms for the player. And we completed these twice a day, but we only completed these every 3rd day. And this again was to ensure that we didn't create fatigue. We've got isometrics every day. We've got heavy slows, and now we've got endurance heavies as well. So we're generating a hell of a lot of lifting through the leg complex. So we have to make sure we didn't get fatigue and DOMS or potential irritation of the tendon. So by day 10, we'd reached this. And the player was experiencing no side effects from the GTN. He was very happy, and we were up to 3/4 of a patch on that GTN. The pain remained stable. We had one little fluctuation around day 7, where we introduced some of the heavy slows, and we also incorporated the heavy endurance, and we had a 5 out of 10 24-hour pattern. 5 out of 10 for the player is something that he's been used to dealing with in the past. But as soon as this was flagged, we just took a little bit of weight off for one day, and then it was back down to a 2/3 out of 10. This sort of improvement continued to day 12, and we began some energy storage work. So energy storage work is your eccentric work. So energy storage within the tendon. So that's slow eccentric load to then allow energy release, which is your plyometric loading. So the assisted concentric was completed. So a bilateral assisted concentric to a unilateral eccentric drop, which was a 6-second drop. So it's just 2 feet up, 1 foot down, for simple terms there. Maximum capacity was reached as soon as possible. So we were stacking the weight as much as we could to ensure that the player reached maximum weight. And then we began energy release drills. So at the start, we began these on an air track. These are basically the big running tracks, which are blow-up mattress, basically. So we were almost giving the tendon an extra bit of spring by using the air track as a rebound board. So we use this to complete mini rebound squat jumps, mini running drills, A skips, B skips. So taking the player through mechanisms of running and plyometric drills. We use this predominantly to create that stretch shorten cycle, which I mentioned, an assisted stretch shorten cycle, and to basically assess the player's tolerance to this new load. There was no pain, no issues, so we were very, very happy with the air track and how that had gone. So the player remained stable, like I mentioned all the way through this, which we're very lucky to get that. It doesn't normally happen with a tendon. You normally get quite major fluctuations in pain, major fluctuations in function. We're very, very lucky with this. And pain remained 3 out of 10 through all 24-hour patterns, apart from one little spike. So before we returned to play, we needed to make sure that our strength and functional markers were where we wanted them to be. So counter movement jump, single leg squat jump, and the triple hop over distance, which I mentioned before. These were compared to pre-injury scores. So when the player was fully fit, no issues, no complaints. So the counter movement jump height, when we assessed this, had reduced by 1.2 centimetres. But this is comfortably within the deviation range that we use at Bristol. So we're very, very happy that that jump was within range for us to allow a return to some pitch-based activity. Saying that score that the player jumped still put him in the top 5 in the squad for counter movement jump. So, again, we're very, very happy where we are. We also looked at the eccentric force using our force decks during this, and there was only a 3% variance with right over left. Again, well within our pre-injury scores and within our variance data that we allow for. The single leg squat jump had increased bilaterally by 0.9 on the right and 0.7 centimetres on the left. So excellent for us to see that in single leg control, the player had improved massively. The pre-injury scores of those is 2.3 improvement overall, 2.3% improvement overall. So again, very, very happy. Triple hop score. So on the right, the player would score 6.5 metres and on the left, 6.3. This was only a 3% decrease from pre-injury. So again, excellent, very happy. We can get much bigger variance in scores on a fatigue test day or on a mid-season test day. So again, excellent. Player only reported a 1 out of 10 pain score during these, and it was very, very happy. And again, we observed the 24-hour pattern after this, and there was no fluctuation. See there, we talked about foot posture. With the player, he had previous foot analysis, so static analysis in a foot mould and dynamic analysis on a treadmill with video analysis looking right up through the chain. So hip position, knee position, ankle and foot position. He'd had orthotics in the past, not with us, but had not got on with them at all. The player has very, very stiff ankle joints into dorsiflexion on assessment. So this started to bring up a few little flags into our treatment that we started to incorporate a lot of ankle mobility work. So we look for our players to be achieving between 20 to 35 degrees and have within 10% variance right to left on their dorsiflexion marker. So we use a gyro for that on the tibial area. When we measure that, we don't use a knee to wall, so it's too crude. So player was a little bit decreased on that. I don't have his exact data, but compared to the squad, he was down. So we started a lot of ankle mobility work, self-mobility work with a band, and therapist-assisted mobility work. So ankle glides, assisted glides. We use some mulligans. We use some manipulations. So a lot of stuff was going on in around the foot. We did have another orthotic assessment carried out, and it was agreed that no orthotics should be prescribed because of good arch position and good foot drive and toe off that the player had. So we're very happy with that. I'm happy that we covered that base as well. It's just something that we've had to maintain with the player all the way through. Lots of ankle work and lots of foot work. You see there, we talk about nutrition. So we started to look at collagen supplementation with the player. So collagen shots in the morning. You see when I start to talk about the literature, there's quite a lot of good evidence starting to develop around tendons and around the use of collagen and around the use of vitamin C. But you have to be very, very specific when you prescribe it and when you give it. Again, I'll talk about that through the literature when I really start talking, even though it feels like I'm talking a lot now. We had to make sure that the player took this religiously. So as soon as they woke up in the morning, it was a collagen shot, so that when they came in for their first bout of loading, as soon as they arrived, it was in their system enough for it to have the effect that we needed at a biological, physiological level. So just another little added extra to the treatment that we could say we were making sure we covered every base with this player. But luckily for us, through all these treatments, it all seemed to be successful. And I can assure you, there have been a lot of tendons that I have treated, we have all treated, that are not successful. So in this case, everything seemed to work. There's probably an element of luck from our behalf on that. But we made sure we covered everything and we were detailed and thorough and methodical in everything that we did. the evidence around patella tendinopathy, or tendinopathy just itself. What does it say? Well, there's a lot out there at the moment. This research that I'm presenting to you is in the process of possible publication. So, there's a lot here. I'll rattle through it as quickly as I can, but I want to make sure I get as much out there to you as I can. Try and flag up if you've got any questions mid-flow, because I'm going to do a fair bit of talking through this. So the evidence, what is it saying? So a lot of the previous research and literature that's out there from years gone by is all about rest, offload, reduce aggravating factors, heavy eccentric exercise to stress the collagen and the tendon matrix. There's a ton of research around that area. Now, this loading incorporates a high load with a high number of repetitions that is aimed to cause maximum stress to the area. This often results in fatigue and a massive increase in 24-hour patterns. So it will affect your day-to-day management of the tendon, which, as we've just spoken about with our tendon, we did not want. And we were advised and we researched that is not the way to go. This technique was successful and it had some good results, but it required approximately and above 8 weeks of consistent loading and management. Now, if you think, if I go to my manager and I say, I need 8 weeks of loading with this player, and he's only got a 2 out of 10 pain, it's not going to go down that well. If I even say that to the player, it's not going to go down that well. So current trends in the loading of tendinopathy are allowing us to get control of that pain and the function a lot easier and quicker. So, that's something that we always have to consider in the nature of the sport or environment that we all work in. We need to get the player back in a safe but short time frame. Loading in this sort of manner that we've just discussed, so the eccentric, offloading aggravating factors, will show a significant reduction in tendon pain early in the rehabilitation phase, because it allows you to just rest and the player can't feel those symptoms. All right, so that's not ideal in this scenario, because we know that we're going to load them again at some point. Their symptoms are just going to spike. So we need to make sure we move away from that, and we need to start going towards all of the recent research around isometrics and heavy loading, which has been found to be effective, arguably, for pain management, but very effective for restoration of strength. There's a lot of conflicting evidence around the pain management on that. So I won't say it does or it doesn't, but very, very good for strength restoration. So we can create that early rehabilitation and that early strength development quickly without cumulative fatigue with isometrics. And again, there's 3 or 4 really good articles around that fatigue basis, which will be in the list at the end. You can get pain relief at times which can last 45 to 60 minutes after you've completed your isometrics. There are papers which say that. There are papers which will argue against that. The papers which do say it, they've got very, very strong statistical evidence to back it up, but they are looking at quite small sample sizes, so just be aware of that. Early reduction in pain is obviously really going to be important for us. We need to make sure that we get that into the player and we get them loading and we get them moving as quickly as we can, pain-free. So that's why we isometrically loaded with this player in question. Very, very heavy. Okay. A lot of the research suggests the heavier you can go with your isometric loading in a single leg position, the more significant the difference may be in your pain control and patella strength restoration. So we talked about this nutrition. So like I said, recent research has come out by BAR. I say recent, 2017, but it's been out and about for a year or so regarding the use of using specific supplementation. So gelatin with vitamin C, so collagen with vitamin C, that should be consumed 60 minutes prior to any loading or influence within that collagen structure. So the vitamin C and the gelatin are said to possibly have an effect on the synthesis within the tendon, which enables a quicker return to function. So vitamin C is added to the gelatin because it enables the athlete to consume the gelatin easier, because it'll add a bit of flavour to it. But it also enhances the tissue repair, which is considered vital during the early phase of rehab. So if we can add that tiny little supplementation to the player's nutrition and we can get them to take that 1 shot or 2 shots a day, even if we're only having 5% effect on the overall picture, we're having an effect. And the research is backing it up.
I didn't get that. Oh. Could you try again?
Sorry. So it is backed up by the evidence. There's no contraindications within this, which is sort of leans you towards, well, why wouldn't I use it within my rehab? It's got amino acids, so it will greatly help the athletes in their recovery. And this was shown through blood testing. So it wasn't just done through subjective scores. There's been a research paper by Shaw that used blood tests to show adaptation to load and how the amino acids affected the blood after loading. I mean, we all know that any form of loading is going to increase strength in both the short and the long term. But if I can just add that tiny little bit of nutrition that's going to give me that tiny little percentage of improvement, then we should all take it and look at doing it. So we've done all those at the start of our rehab, like we said, and then we started to move forward. So looking at the evidence for eccentric and then through range. Again, there are shed loads of research papers around this area. Also, a lot of these research papers back up that no manual therapy or secondary treatments are considered effective or should be prescribed for patella tendinopathy. They can be avenues to look at. I'm not saying you shouldn't, and the evidence doesn't say you shouldn't, but they're not going to have an effect on your tendinopathy. So massage is going to have no effect. Ultrasound, no effect. Shockwave, very debatable. Okay, some evidence for, a lot against. But your main background or basis, foundation for any of your patella tendinopathy should be load, load, load. And there is so much research to back that up. So, like I said, we didn't apply any other treatments really, apart from looking at mechanism or mechanics of the body and the foot posture. But we did look at the GTM patch. There's evidence around there. There's 2 very good papers that show that long-term GTM patches can assist in the management of pain and function. A lot of variance on how individuals will manage that pain, especially the headaches. But the problem that GTN often has is it needs a long-term effect, and the research suggests approximately 6 months of consistent use. Now, you'd have seen that we had possible effects very, very quickly. Was that the loading or was that the GTN? I couldn't tell you, and I'm not going to say it was one or the other, but it didn't have a negative effect on our player. But the research says 6 months of consistent use, there is a significant change in an athlete's ability to load and their reaction with pain. Again, it's supported by Shalumas, another very good recent paper, who studied the effects of GTN with pain and eccentric loading. And again, 6 months is stated again in that paper, showed excellent effects on reduction of pain whilst loading a tendon. Very good, strong confidence levels in these papers, very good odds ratios. So, they are good, strong papers to look at. They had 24 weeks where they started to get the initial decrease in pain, which again is a long time for us in our profession. We haven't really got 24 weeks to wait, but that's what the evidence is suggesting, and that's where the paper is saying you should look to really notice your big differences. GTM patches have, like I said, pain, and they also allow that heavy loading because of the controlled pain. The 6 months is noted in one of the papers about its hindrance in a return to sport activity, because if you get patella tendinopathy in October, you're not going to wait 6 months and then the season be over for you to say that your GTM patch has had an effect. So we have to look at the real world in compared to some of the evidence that is being thrown around. MRI scanning and ultrasound scanning. There's a debate of which one is better. Both widely used to establish severity of all pathologies, with excellent success and excellent success within the patella tendinopathy. That's supported by Maliares, Cook, Khan, Pizzolato. There's a lot of evidence out there to suggest use both scans. Ultrasound scan is often the preferred diagnostic tool within the evidence, but you just need to use it within the player's symptoms. But if a player's got a 1 out of 10 and pretty much what the scan is going to say. Do you really need to go ahead and ultrasound an MRI? Some may argue yes, some may argue no. I'm talking about myself here. Our player had an 8 out of 10, so it warranted a scan. So, you need to leave that down to your own clinical judgment as well. A lot of the Maliaras and Cook and Calm work suggests that you need to probably be guided by an expert, so a consultant. We scanned ours before we saw our consultant, but he still conducted a secondary ultrasound scan on the spot there and then. They will often use a high-power coloured Doppler, which allows you to see the neovascularization, the tendon change that's taking place. An MRI can be used really specifically if you want to see if there's a tear. Now, obviously, we did an MRI and it suggested a tear. I use that word carefully, suggested a tear. Our radiologist did not want to confirm it, but then our high-powered and high-coloured Doppler suggested no tear. So that's where the evidence backs up what we did and why we did what we did. We used that Doppler to rule out a tear and to establish where the neovascularization was taking place. So both of the high Doppler and just a normal Doppler ultrasound have got very high inter-rater reliability. And that's obviously very important. If we go off to see a specialist and we come back and use our own radiologist, we know that the inter-rater reliability between what they're seeing is going to be very, very high. And that's backed up by 2 or 3 papers to support that. So we were more than happy to then monitor our player based on this evidence with our own radiologist, rather than travelling off to see the specialist all the time. And the accuracy is also shown to have very high significant levels. So we knew what we were getting was sensitive enough to maintain and manage our player throughout the process. There is some research around the accuracy and diagnosis of MRI and ultrasound. So that's grey against colour. So there's an accuracy levels of 70% to 83% from an MRI to the ultrasound. Right, so very good. The sensitivity levels is only considered at 57% for an MRI, whereas it's 80% for an ultrasound. And that's where it comes into the detail of picking up on the little nuances within the tendon. And obviously with the ultrasound, we can do dynamic scanning as well. So we can look at how that tendon behaves under and knee extension or during a squat if we want to. And again, backed up with high levels of sensitivity within those tests. MRI and ultrasound should be used for diagnostic purposes, but there's a big argument against an abnormal MRI may not correlate to the symptoms that you are seeing with your patient. So you might see something in an MRI and think, there's a lot of damage going on there, there's a lot of collagen change, there's wavy matrices within the central tendon, but then you see the player and I'm a 1 out of 10, I can run, I can jump, I can do anything. But you're looking at the scan thinking it can't be the same player. And this is backed up through strong evidence to say that we shouldn't solely rely on the scan. You need to consider the player's symptoms. If I was to take every scan of every player, I think 90% of my squad would probably have tendinopathy somewhere, but only 1 or 2 are reporting symptoms. So it's about that clear holistic picture that you generate. And we try to do that with all of our players, and especially this case. We could see that there was a fair bit going on at the infrapatellar pole, but the symptoms were settled and the symptoms were in control, and he was happy and performing at levels above and beyond or just below. So we were more than happy for the player to continue. And that's where it's important to correlate everything throughout that. So the insertion changes that can occur within tendinopathy are very, very easy to appreciate in an ultrasound image. And they can give you appreciation of those results in a much clearer fashion than MRI. That is specifically around the insertion, into the infrapatellar pole, which is why we looked at ultrasound for ourselves. That's not saying that a central tendon or a distal tendon is considered in this. This is specific for this player. We needed to establish through these ultrasounds what was normal. So hence the fact we ultrasounded a couple of times. So what is normal for the player? What changes are normal? Backed up by the evidence that the ultrasound was the right way to go and would allow us to rule out coexisting conditions. Now, MRI and ultrasounds have a big place in our diagnostic procedures, and we should use them. But like I've already said, and I will reiterate, patient symptoms should always be in line with a scan, not one or the other. You go off a scan, you're going to get yourself into a hole that you might not need to. So there is massive value in a scan, but the player is always paramount. All right, so conclusion moving forward. So I've talked a hell of a lot. I realise I've just been speaking non-stop. But it's an important condition that we need to recognise and we need to manage properly, especially with these elite, high-end athletes that are very powerful, very strong and very quick. We need to understand why it's happening, understand how we can control it, and understand where we go moving forward. It is an ongoing management. It's not something that we can manage in a week or 2 weeks, like a little bit of swelling from an ankle inversion. We need to manage this for the rest of the players' career. So you have to manage it going forward forever. Not something that we can switch on, switch off. All of our players that have had tendinopathy issues will remain on isometric and heavy loading days throughout the whole season. Yes, this will be periodised. When you move forward with your players, you have to periodise that load to make sure you get it right. Your energy storage and your energy release drills should be completed weekly. That should never be excluded out of your programme. And these can be done in little 5-minute blocks, 10-minute blocks. They don't have to be done in an hour where you're going to risk possibly getting a spike in load and a spike in pain. So think about nutrition. Think about foot posture. Think about body mechanics. Think about lifestyle. What does the player do away from us? These are all things that you should always be thinking about when you're looking at your next tendinopathy. What is the player actually up to away from you? Is he doing his loads at home? Do you need to get equipment to his house? Do you need to make sure you get him in at the gym? You also have to think about how the player is living his life. You're not going to get a player in at 8 o'clock at night to do 5 minutes of isometric loading when you're just going to get a complete rebound and rebuff from that player and he's never going to want to listen to you. But you have to get load in. I think I've said load about 1,000 times in this presentation. Load, load, load. There should be nothing else you should think of primarily apart from loading. I think that pretty much covers it. Awesome. I need to drink badly. So any questions? Go ahead.
Yeah, the questions are looking really good. I've made about 3 pages worth of notes there. I think there's so many reflection points, and every time we discuss a clinical case study in pro sport, it's always fascinating how much detail goes into it and how everything is considered. It's always no stone unturned. I'm just going to turn my camera off because otherwise everyone's going to be staring at me, reading all the comments. So I'll take some of the top voted ones first, but then we've got some potentially controversial questions as well, which are always a little bit of fun towards the end. Okay. So Danny Barnes is interested in your load monitoring. So you brought it up early doors in the case study that particularly with the 8 out of 10 spike, you'd seen how the players loading had contributed to that. So what tools and systems are you using to monitor that?
Yeah, so like most professional clubs now, it's not just even at the top level. So GPS. So we don't necessarily look at the 1.5 ratios that get banded about. We look at our own periodised programme. We look at specific percentage increases. We look at percentages of total distance to high speed running. We look at number of sprints, accels, decels. So we look at all those pieces of information and we bring them all together as one. And then we look at the increments that we can generate against the total weekly load, which then creates a chronic load for ourselves. And that doesn't necessarily have to be over a 4-week chronic load period. It might be 3 weeks, it might be longer. But we try to monitor those key variants. And we saw with the player that, like I said, came back into pre-season training late. So missed out on almost the foundation level of week 1. Yeah, which is very, very low numbers, getting the body moving, getting used to the football again. So that's looking after our groins, and that's our groin management. That's a whole other minefield. Came in, off the top of my head, around day 10 of pre-season. So was playing catch up. So had a massive spike of like 0 into what would have been a normal week then for the rest of the squad. playing 245s in 72 hours, which would have been normal, but being the player that he was, had to play in them because we needed to get him fit for the start of the season. So that's where the spike came in, and you could see on his load that he was a massive red dot that week against him. He had something like a 40% increase in load. So own fault, it happens, and it will always happen because you sign players, and that's just the way it is. So yeah, that's what happened with his loading and how we monitor it.
Awesome. I guess that's always the conflict as well, isn't it? Between, a talented player getting injured, coaches, managers want him on the pitch, and you're trying to manage his load, and it becomes difficult. But without monitoring it appropriately, you're never going to know, and that's why it's so important. Kind of feeding into that, a great question from Jenny is, how was his, one, on-pitch and technical skills managed during the rehab period, and also his cardiovascular fitness? And was he doing anything alongside his specific loading?
Good question. Ironically, I've just added that into my publication yesterday. So, so alongside that, the player started off in the initial 12 days of off-feet loading. Cardiovascular-wise would have been battle ropes or ski erg. So we use those two devices quite brutally, but a lot. You can be very effective, very short and sharp sessions. So we could do intervals with either of those, or we can do longer steady state work, especially on the ski erg in a seated position. So we're able to maintain players' cardiovascular systems like that. The player in hand then entered the pool and did a period of pool work. So 4 to 5 days of conditioning work and tolerance load work in the pool, which is vital that we've got access to that. The injury wasn't long enough for us to warrant going for an Alter G or any in-between phase like that, because the player was only out for just over 30 days. So very lucky that we managed to get control of it quite quickly. But with a normal severe tendinopathy, we would go hydrotherapy, Alter G to maintain the running mechanics, to maintain the fitness before hitting pitch-based stuff. And then the pitch-based work becomes very closely monitored, with making sure we have total distance in the red, we have a high-speed distance in the red, zone 5, zone 6, like I've already said. But lots of other stuff going on, loads of gym weight work going on. The player in question is very, very good in the gym, is very keen to work hard, so it makes life quite easy when you've got a player like that you can keep fit throughout the process.
Cool. Your ankle stuff's kicked off a few questions. So I'm going to try and group some of them together. But Danny, again, so would you say that the lack of ankle range into dorsiflexion was one of the main contributing factors to the injury? And then to tie in one of the others as well, in terms of some of the treatment you were doing around the ankle as well, and efficacy of it, how important was the hands-on work in terms of manipulations and mobilizations?
Okay.
And improving.
Do I think it's a contributing factor? Yes. Do I think the player needs the dorsiflexion for the way they run? No. If you saw the player hit at hand and how he runs like a sprinter, so he's very stiff. So that's a way that he's been developed and the way he's been coached from a young age to run.
Possibly helping his jump mechanics as well. He said he had a good jump and good speed as well.
Physically, he's one of the strongest, quickest, highest jumpers probably in the league. So would I really want to get rid of it? No. Would I want to help it a little bit? Because it clearly is a contributing factor to the tendinopathy. Yes. The efficacy of hands-on treatment to an ankle joint.
On the spot.
I don't want to get into a big debate about whether hands-on treatment works or whether it doesn't. There's enough other people to do that. Does it make the player feel better? Yes. Do I feel like I'm having a positive input on the player because he feels better for it? Yes. Does the player's ankle range of movement increase straight afterwards? Yes. Do I test it again 10 minutes later? No. But those first 3 of yes, player feeling good. Oh, my ankle feels like it's moving better. I'll take that every day of the week.
Yeah.
I will take that and I will be delighted with that. Right, let's go and do some energy release drills. Yeah, brilliant. I feel really good. That's fantastic. I've done my job there.
Gets you some buy-in.
Have I biomechanically changed that player? No. I'm never going to claim that I have. But like you just said, I've got buy-in. I've got a bit of euphoria that we've achieved something. The player feels great, and that's 9/10 of the law with a lot of the stuff that we do.
Yeah.
So yeah, I wouldn't say there's any efficacy to what I do at all.
Cool. I've got a controversial one for you in a minute. I'm going to save it. You mentioned and touched on it briefly. The maintenance work that you were doing with players that have had tendinopathy as you then go throughout the season. Can you just elaborate a little bit on the maintenance protocol? So maybe, I don't know, frequency, level of loading compared to the rehab phases, things like that.
Yeah. So anyone that's had a tendinopathy, we have targets for them to achieve. So it will be a single leg isometric capability of 4 45-second holds at 1.5, 1%, 100% body weight. Get my words out. And then a soleus hold if it's an Achilles of 150%. In the patella tendon, 100% hold, 4 45s. So you can see there's a trend for what we're looking for. We're looking for a body weight hold. Now, on a single leg knee extension hold, you're not going to get that. On an inverted unilateral leg press, you are going to get that. We don't have access to that. Our training facility, we've got a pretty old school leg press, so it doesn't really work or give us the capabilities for it. So those are our targets. The isometric work the lads do, we do a lot of isometric work at the club because it doesn't create the fatigue. Now, if a player's playing every week, I won't expect him to do his isometrics 3 times a day on a Friday before a Saturday. So we will periodise it and say you will do an AM load, so that will be a pre-training load of your isometrics, 4 45 seconds, done. We may even take him down to 80% load if the player's saying, subjectively, I feel a little bit tired. So again, it's just that give and take. It's that playing it a little bit. We wouldn't have a set structure of, no, you have to do 100%, otherwise the evidence says it doesn't work. No, again, we get the buy-in and we still get load into the tendon. So again, it depends on your week. If we've got a 2-game week, the player will probably only do 1 isometric load on a Monday. We'll play on the Tuesday, 1 isometric load on a Wednesday, 2 isometric loads and a heavy slow on the Thursday, 1 isometric load on the Friday. So you're still creating that mini little undulating peak within the week. If it's a flat week, we can get in a heavy slow day on a Tuesday, and we can also get in a heavy eccentric day on Wednesday, and then they can have a day off on the Thursday with 1 set of loads at home. So you can see there's always capabilities within every week to shift your pattern and still get in your load.
Yeah. Awesome. Cool. We're running short on time. So one thing quite a few people are asking is, can you just give us a few seconds of each of your reference slides? Because I think people want to pick up some of the references. We've recorded this, folks, so you'll have access to the recording. We'll send you out a link. So if you want to be able to check back on these references, you're going to be able to come back on the video recording and get them all. And I know a lot of them were mentioned throughout as well with authors, so you can always go away and do your searches. I'm just going to probably pick out the one last question that will fire your way, and then we're going to have to wrap it up for time, unfortunately. Okay, there's a nice question from Tony Reed. So, any correlation with players training on different surfaces? So, 3G, 4G, grass, and would you differ your rehabilitation with players playing regularly across different surfaces?
We're very lucky that we don't have to worry about that. But in the past, I've had major Achilles issues at another club that I worked at through changing of surfaces. So I do think there's a correlation. I know that Dave Rennie's done a lot of work around that, but regarding other injuries. But I think there is a definite argument for changing surfaces every week, and that will affect the lower league clubs. And that's no disrespect, because I've been there and worked there. That when it is raining, your training pitches are not appropriate for that. So you have to go to an artificial surface. Then you go to your match day and you play on a slightly muddy pitch. Then you play another game on a Tuesday, which is a hard surface, which is completely different again. So I do think, and I do agree, that those changing the surfaces will have an effect on all the tendon structures that we've discussed. The ability to manage that, if I could answer that, I wouldn't be working for Bristol City. I'd be a millionaire sat at home chilling. Yeah, I don't know is my honest answer to that. I will always say, if I don't know an answer to something and I don't know the answer to that,
that's a great way.
Try your best to try and replicate what pitch you think you might be playing on, but you can't predict the weather, especially in this country.
Yeah, that's true.
And that's the problem. Like I said, we're lucky that our pitches are maintained, and we have a pitch which is exactly the same as Ashton Gate at the training ground. So exactly the same grass, exactly the same size. It's exactly the same. A lot of clubs don't have access to stuff like that. So it's very difficult to maintain and manage.
Awesome. That's a really nice way to wrap up with the I don't know, which is always one of the best answers to a question. Leave people curious and let people go and do their own digging, which is great. There is still loads of questions sat there. There's no way we're going to get to them all. Just let people know where they can find you on Twitter, because I'm guessing there's going to be quite a few people that want to fire follow-up questions your way after this.
Yeah, just look me up on Twitter, guys. Just at Andrew Proctor, and just direct message me or something. I'll put it out there and tag people in it, whatever. I don't mind. I will do my best to answer. Yeah, go for it. I'm quite happy with that. I'm quite intrigued as to what this controversial question was.
Oh yeah, all right. 30-second answer. I've got a feeling I know what you're going to say. Acupuncture and electroacupuncture in the management of tendinopathy. Yes or no?
No.
I thought so.
Bottom line, no.
I thought so.
No. Yeah. No, I've got no evidence to really back it up. Have I used it in the past? Yes. Would I use it now? No. That's anecdotally and lack of evidence based.
More time to be spent doing more useful things, for sure.
Yeah. Like loading.
Loading, yeah. The word of the day.
Yeah.
Cool, right. We're going to wrap it up there.